So I will talk about a white paper, which is a kind of a policy paper from the European Association for Palliative Care on palliative care with dementia. And for months it was the most read or most downloaded paper in palliative medicine, but now the Liverpool Care Pathway beat us. And the third place is for your work, and I think the top 20 is kind of filled with your work. Going back to 2010, we developed a remit in which we said what we wanted to do is to define palliative care for dementia patients, and we wanted to contrast it with palliative care for other patients, to describe core issues and to provide future directions. And this is because it wasn't clear at all what is palliative care in dementia. In these reports of WHO and World Alzheimer Association, they were talking about end-of-life palliative care. And they said that this was a special form of continuing care when patients are close to the end of life. So if there's end-of-life palliative care, what is the usual palliative care? And then they're also talking about a journey of dementia care from diagnosis to palliative care, which again suggests that it is at the end of life, always. So there's a lot of conceptual unclarity. So that's where we started with the applicability of palliative care in dementia. So how is it different from palliative care in cancer? We also looked at prioritizing care goals as another conceptual issue. And then I'll talk about the white paper, how it was developed. And what we did is to define palliative care in terms of 11 domains. And we also said what is optimal palliative care with 57 recommendations. So, and in the paper is also a research agenda. And I will talk a little bit at the end about dissemination strategies. So, does palliative care apply to dementia? Well, there are good reasons to believe it does apply, because dementia cannot be cured, it is life-limiting, it involves patients as well as families. Patients and families have complex and very specific needs. Anticipation of problems is important, and it is a kind of person-centered, holistic and multidisciplinary care with a focus on quality of life, which fits very good with dementia care. And a good death means a dignified death, and a low symptom burden is also important for patients with dementia, and we have asked families about it, and they find this equally important. And some people suffer from some have a high symptom burden. And I can show you with this graph. It's from the Netherlands in the last week of life. And we report pain, shortness of breath, and agitation if it was there more than 1 day in the last week. So then half of people are in pain, and over 1/3 have shortness of breath and agitation. And the percentage is really much higher if you also count the 1 day in the week. And this was a study which was representative of the Netherlands. And then one other conceptual issue, in addition to the applicability, is care goals. Is it any different in dementia? Well, we think it is. This is, well, in the Netherlands we say this is a new model, but perhaps it's already a bit an old model. Lynn and Adamson's model talks about disease modifying. But there's not much disease modifying in dementia, not much. And then symptom management, is that the same as palliative care, or perhaps palliative care is broader than that? It starts with some level of palliative care with symptom management. I don't know, I don't understand why, but it is there. And then family bereavement is only after death. And on the x-axis is time. So we felt it is a bit different in dementia. We developed this model, where there's not treatment on the y-axis but goals of care. And one of the goals is a prolongation of life, and there are two other goals, function and comfort. Bereavement support is very subtle, but it doesn't start after death, but it is there all the time. So the anticipatory grief with each step when the patient declines is there. And then we have dementia severity, which may be more relevant than time on the x-axis. And the quality of life comes in here. I think it fits best with a goal of maintaining a functioning and comfort. So then we still have a triangle like in the older model, and yet it is a different model. So I talked about the prioritizing of care goals, and now we move on to the defining of palliative care in dementia. What are the important domains? And optimal palliative care and the research agenda. And this was all based on both evidence and consensus among experts. So we did a Delphi study, which is really aimed at reaching consensus and can build in the evidence for that. And the first round was in 2011. With the core team, we drafted the domains and recommendations. And then we had 2 rounds of evaluation by experts with feedback. And then the 4th round was revision and decisions by the core team again. And in the last round we had input from the EAPC board and national member organizations. So the first round was qualitative. It's part of the Delphi study. We drafted domains and recommendations. And it was based on the literature, and we used reviews were available because we were not able to do a systematic review on all of those topics that belong to palliative care in dementia. And we used the clinical experience of the team. We had a team of 12 people from 6 countries, mostly European countries, with really different expertise. The expertise we thought was important, that I was not the only one who developed this. Lucas Radbrug did a lot of work on this. He's from the EAPC. And then we had Anneke Franke from the Netherlands, Raymond Koopmans from the Netherlands, and from the UK, Julian Hughes, from Ireland, Phil Larkin, and then Ladislav Walliser, the founder actually of hospice or palliative care in the US in the 80s. Pam Firth from social work, and 2 colleagues at VU University, Kees Hertog and Marieke de Boer. I don't know, perhaps I forgot someone, but I'll move on. So this is how it looks like. This is the first domain. Applicability of palliative care is a domain in itself. And the first recommendation. And what we did is we had the recommendation and we had some explanatory text. And the text was backed up with references and evidence. The next 2 rounds was the evaluation by experts. We invited people from 27 countries and we got people from 23 countries. Well, 2/3 were from Europe, but the other 1/3 was from North America, Australia. We had 1 expert from South America and some from the far Middle East. And this is what we asked them to do, is to evaluate the draft recommendations, and then they could say if they agreed with it or not. And the final the rating is the importance of the domain, and this was on a 0 to 10 scale. And they could provide, with these open-ended questions, they could provide any feedback about the recommendations and the domain. The importance as a whole was evaluated with an 8.9 on a scale from 0 to 10, so we were, that was very satisfactory. This is what the domains looked like. There were 11 domains. So the first was applicability of palliative care, and then we had person-centered care, advanced care planning, continuity of care, prognostication, two kinds of treatments, aggressive treatment and symptom treatment, and then psychosocial and spiritual support. Family support was a separate domain. And we also had two domains, well, not really directly for practice, but for policy and education. So these were the importance ratings in the first rounds, and we wanted at least an 8 on average. So there was one domain that didn't reach the bar, it was prognostication. And we had to revise it, and then fortunately we could keep it in the second round. And these are really the highest valued domains is the treatment of symptoms and the person-centered care. It's kind of universal that these things always come up when talking about the good death. And so what is different with palliative care in cancer patients? We compared with a US project that really detailed about domains and recommendations, a national project, and then they do not have a separate domain of applicability of palliative care. We have more of an emphasis on advanced care planning. They don't have a domain on prognostication, and we have more of an emphasis on family care and involvement. And of course, these are the domains, but there are also differences at the level of the recommendations. And there are more differences, of course, and you can see it in the recommendation, that is the communication with the patients, the behavioral problems, which can be challenging in dementia. And the meaning of spiritual problems is not well understood. And there's a lower level of evidence overall. And the setting of death is much more frequently in long-term care. And this is what we did not anticipate when developing the remit, is that there are also differences, of course, with usual dementia care. And people working in dementia care said, well, we are doing this already, so what's new? So there is some conceptual work to do as well. And I've looked at the Dutch report on the guidelines for dementia care, and then I feel that we have more of an emphasis on the advanced care planning again, and anticipating death and recognizing the dying phase, and also the systematic monitoring and addressing of symptoms is not really being done in dementia care, and the inclusion of pre-grief and bereavement care, but not so much a pre-diagnosis trajectory. And it also, the palliative care in dementia includes an explicit focus on spiritual care, and much less so on like aging in place, the physical environment, and practical issues like managing finances. And so one important difference is the anticipating of death. And so it's important to know if this is really helpful in dementia. Well, perhaps it differs between individuals, but overall we have some indications for that, because we found that if families believe that dementia is a disease you can die from upon admission to a nursing home, then the patient's death was more comfortable. And we wanted to know if we could explain this, and it was in part explained by physicians believing they could provide better care and a better relationship between the patient and the family. And the next question, of course, is that should we make people believe that dementia is a disease you can die from? And there's a lot of work to do in, well, perhaps not only observational work. So now we move on to the specific recommendations. This was the first one. You've seen that one before. And this is how the experts rated it. So 3/4 strongly agreed, And then we said with a median of 5 that was strongly agreed, and we also looked at the interquartile range, there was a consensus. So we accepted this one immediately. This wasn't true for all, and we were a bit more flexible. We also accepted when there was an interquartile range of 1, and then we said there was high agreement. And this way the panel immediately accepted 51 of the 57 recommendations we drafted. And the 6 not immediately accepted refer to applicability of palliative care again, and in which stage of dementia, the discussion of prognosis, and nutrition and hydration issues. So this was one of the recommendations where we had no consensus initially. We said that palliative care applies to dementia throughout the disease trajectory from diagnosis until death. And we revised in the next round. Here's the rating in the first round. So we had less than 80% agree with this one. And here are some examples of the critiques. Important to distinguish early and advanced dementia. It's not appropriate to name it a terminal condition from the beginning. And this is an important one. We should not relabel dementia care as palliative care. And when really looking at the comments, it seemed that some dementia care specialists were really concerned about their expertise and what new we would bring to them. So this is, I'm still analyzing this, the different responses from dementia care and palliative care experts, that palliative care experts were a bit more positive than the dementia care experts. So in the next round we revised and we provided a summary of feedback to the panelists. This is one other comment, concern of giving up. We call it palliative care. We revised and we said we're a bit more careful. We said it can be considered appropriate rather than it applies. And we added that particular goals were changing over time. So still we didn't achieve agreement. And so we needed another revision. And then one of the comments was these goals are not exclusive to palliative care. So then we did a subtle change. These are also goals of palliative care and changing over time. And then in the last and the fourth round we had agreement. So the other 2 recommendations were on the domain of prognostication. There was some critique about the tools we had in. We recommended use of tools, and many were not convinced that these were helpful. So what we did is we emphasized the combining of the clinical estimate, the clinical judgment with the tools, because there is some evidence that this really provides the best predictions. And we talked about timely discussing. I think first we said something about early discussing, and then people were concerned on how early should we do this, and should we discuss with all. And the last area of which was controversial and which really remained controversial was dealing with intake problems. So we didn't achieve full consensus here. There was one recommendation on hydration. And we said providing rehydration is inappropriate in the dying phase. And actually we thought we should keep it this way. And the other one was about tube feeding. So we revised and still didn't achieve the full consensus. Because, well, some preferred a more individual approach, so they were concerned that you shouldn't be dogmatic about it. And then I move on to the last topic of the white paper is a research agenda. We asked the experts also to prioritize the domains for how important they are for research, if they, and then they responded that it was the decision making, So person-centered care and decision-making and advanced care planning, domain 2 and 3. And also the treating of symptoms. It's really a priority area for research. And we added a recommendation to do research across Europe and compare care models and make use of that. I think that's our strength in Europe as compared to the US, that we have so many different models, and well, it could be informative just to compare treatments and outcomes. And we recommend further research into how to give shape to palliative care across dementia stages, and in particular in the earlier phase. So what is next is dissemination. The EAPC collective member associations are invited to translate it in their own language. And the Russians were the first. It's already on a website, a translation in Russian. We are still working on it, and the Czech Republic is still working on it, because it's a lot of words, the supplement with the recommendations and the explanatory text. And it's still difficult to, it was more difficult than I anticipated to translate it into Dutch. Yeah. There were some terms that we thought we should really have the best term for practice, and some things, how would you say it, were formulated a bit differently, and we allowed some more flexibility in Dutch to not translate it literally. And that is the direct the translation, but perhaps it also needs local adaptation or some more explanation and information on local initiatives. And we would like to do that and discuss it with focus groups, with people in practice. We're not that far yet. In the 5th round, there were some national member organizations who commented on the initiatives they already had taken, how they could integrate it with these initiatives. So this is a summary. In general, we had, I focused on the controversial issues, but in general we had high levels of consensus. Well, the experts were mostly from Western countries, that's a limitation. So we defined palliative care and dementia in terms of domains and optimal palliative care, with recommendations for practice, policy and research. And then the areas of lowest consensus was when palliative care applies, which stage of dementia or from diagnosis, the discussion of prognosis, nutrition and hydration. And so there's differences in palliative care and dementia as compared to palliative care and cancer, and also to usual dementia care, but there are also similarities. And that's that all of these approaches are aimed at quality of life and should be person-centered. And we're seeking for appropriate levels of care throughout the disease trajectory.